the treatment of concussion has changed. It changes all the time. I had someone come to me in a situation where I was giving a deposition on a case, and the lawyer said, well, doctor, we have it here that in 2015, this is what you said. And I said, listen, this business changes every day. What I said in 2015 certainly doesn't apply to what I know today. I mean, this is science. But lawyers think that once you've said it, or they have a record of it on a blog or on this podcast, that it's suddenly set in a tablet somewhere. So anyhow, it's going to change. And I think that's hard for a lot of physicians unless this is something you do a lot.
That's Dr. Anthony Alessi, board-certified neurologist specializing in sports neurology, speaking about how fast the state of the science continues to advance when it comes to understanding and treating concussion in athletes. And he would know. He's the neurological consultant for the New York Yankees and the Connecticut State Boxing Commission. He's been working with elite athletes across a broad range of sports for more than 3 decades. He's seen a thing or two, not only about the advances in research, but also in terms of applying those advances in research within the more complex context of treating athletes as the unique individuals they are, holistically taking into account their personal stories and circumstances when creating a plan for treatment. You're listening to the Be a Good Wheel podcast, the show where we explore what it means to be a good wheel by digging into scientific research and personal stories about human potential and performance. I'm your host, Amber Pierce. Our guest today is Dr. Anthony Alessi, a board-certified neurologist specializing in neurology, neuromuscular diseases, EMG, and sports neurology. Dr. Alessi is a clinical professor of neurology and orthopedic surgery at the University of Connecticut and is the director of the UConn NeuroSport program, a comprehensive interdisciplinary program for athletes who suffer from neurologic injuries and persistent neurologic conditions. He has served as a consultant to many professional and collegiate sports organizations, including the UConn Huskies, New York Yankees, NFL Players Association, WNBA, U.S. Ski Team, Professional Bull Riders, U.S. Coast Guard Academy, Connecticut Boxing Commission, and more. He was named Ringside Physician of the Year in 2009 by the American Association of Professional Ringside Physicians for his efforts in making boxing safer. When I experienced the worst concussion symptoms of my career, I went to UConn Health to get checked out and could not believe my luck when Dr. Alessi walked in the office. Here was a neurologist who not only knew the physiology inside and out, but who also understood the mind of an athlete. I'll never forget how scared I was walking into that appointment and how empowered and hopeful I felt walking out after speaking with him. Dr. Alessi's unique combination of medical training, clinical practice, and work with athletes across multiple sports makes him uniquely qualified to speak about the state of the science, as well as the more nuanced considerations of treating individual human beings like me, who suddenly find themselves dealing with frightening symptoms and a confusing landscape of conflicting information about concussion and brain injury. With decades of experience helping athletes navigate some of the most vulnerable and challenging moments of their lives, Dr. Alessi is deeply sensitive to the unique needs and stories of each patient, and to the complexities of applying theory and research in real life. Our conversation covers a lot of ground, and because this is such an important topic, we've linked a summary of key points in the show notes. Of course, I should make clear that this podcast is for informational purposes only and is not intended to replace professional medical advice. My conversation with Dr. Alessi includes questions submitted by our newsletter subscribers. If you want to get advance notice and submit questions for our podcast guests, go to beagoodwheel.com to sign up for our newsletter. I'm so pleased to welcome to the show today, Dr. Anthony Alessi. Thank you so much for joining us today, Dr. Alessi.
Thanks for having me.
We are going to try to cover a lot today. I sent Dr. Alessi a very ambitious list of interview questions. We had some really insightful questions from listeners who wrote in, so we're going to try to get to all of those. And the way I want to start, to kind of talk about your background, Dr. Alessi, and then from there, folks will get into more of an overview of brain injury. We'll get into some practical guidance in terms of diagnosis, treatment, prognosis, prevention. And hopefully we'll be able to talk a little bit more, dig in a little bit more on the research of brain injury. And yeah, we'll see how much we can get to today. But Dr. Alessi, I want to start by asking you out of curiosity, why neurology?
Well, it's very interesting. You know, you brought up actually some old memories of how I got started in sports, which was really as an athletic trainer. And I don't
Mhm.
advertise myself as an athletic trainer because back then I was in high school and becoming an athletic trainer was a correspondence course. But I
Hmm.
found that I was playing football in high school and got injured, and I just started becoming involved in the injury aspect and working with our school athletic trainer who needed an assistant. And I suddenly realized that I had more potential in the medical field than playing football. So that's how I got involved in sports. But, after going to medical school, I really didn't have much contact with it. I chose neurology, or neurology chose me. I actually, you go through these things in medical school where you're going to do this, that, and the other. I thought I was going to do ophthalmology and
Hmm.
came back to New York, and I was doing my internship in New Rochelle, New York. And one day a nurse said to me, she said, why don't you ever think of going into neurology? She said, you do so well with these patients in our ICU who have had stroke and these other problems. And I always loved neurology, and I never really thought of myself as a neurologist. And I called around to places where I might be able to apply. And at the University of Michigan, they just happened to have an empty slot. Somebody canceled. And they said, well, if you could be here in 6 weeks. And I said, yeah, I could be there. And sure enough, I went from a small community hospital in New Rochelle, New York, to the University of Michigan, where I did my residency and fellowship, and eventually spent some time teaching. So it was a great place to be. So neurology kind of found me, and actually, I still stay in touch with that nurse. I spoke to her a couple of weeks ago. She's retired now, but just an offhand comment to somebody, kind of praising them. I mean, even at an older age, sometimes you can give somebody that little bit of encouragement that changes their whole perspective and their whole view of themselves. And obviously, changed my life and my family's life because now I have two daughters who are neurologists. So it really changed everything. And it was just kind of an offhand comment. So I guess there's something to be taken from that.
Oh, yeah. I think it's easy to wonder and about how much of a difference a person can make as one individual in the world. And it's so nice to hear examples like that where a really simple observation with, sincere intent can have such a major impact. And now, obviously, like you said, it wasn't just an impact on your trajectory, but everybody
Sure.
that you've treated. And we'll get to more of that later. But yeah, yeah. Remember, folks, you have a lot of potential to make impact for people in ways that you might not even realize. I am curious. So, in the introduction, we talked about how you've been involved with a lot of really major athletics organizations. One of them, of course, I think when people think concussion, they automatically think about football. And you have been involved with the NFL Players Association. How did you end up involved with the NFL Players Association?
This has been this real evolution of a career that I didn't intend to have. In 1995, the New York Yankees moved their AA affiliate to Norwich, Connecticut, where I was in practice. And I started working with the team. They would call me for things, whatever needed to get done, and developed a relationship just working with them. And they invited me to come to spring training and said, we've never worked with a neurologist. Now, you have to understand, 1995, we weren't talking about concussion much. A matter of fact, throughout my career in medical school and in residency at the University of Michigan, I never heard the word concussion more than 5 times
Huh.
because it's such a vague diagnosis. We never use that term.
Mhm.
It's not something you just nail down. And now, let's face it, we're doing a podcast on concussion. You can't open a magazine. You can't watch a sporting event with somebody talking about a head injury or a concussion protocol. So the word concussion itself is such a vague term, but yet the Yankees said, we've never worked with a neurologist. And we started working together back then. Shortly after that, as I said, I was in Norwich, Connecticut, and we were close to the Foxwoods Casino and Mohegan Sun Casino, and they hosted a lot of fights like other casinos. So they asked me to come down and go to a fight. Now, this was pretty weird because I'm a neurologist and I'm going to watch two people beat each other up. But I went to the first one and the commissioner said, well, what do you think? And I said, well, I don't really mind helping you, but do I get to end the fight? And he said, yeah, that's your job. He says, you think the fight's over, you just get up and end it. I said, wow. Then I'm your guy, as long as you're okay with it. So suddenly I was in a situation where I was watching and watching brain injury. I say it's almost like having a lab. I mean, let's face it, these are cruel sports. I mean, if we put two animals in there, they'd be taking me off to jail. But if you put two poor people in there who need a check to beat each other up and neurologically impair each other, that's a sport. So it's pretty weird from that standpoint. Yeah. So I saw myself and continue to see myself as an advocate for the fighter, for the person in there. Because in boxing, just think about it. I mean, in boxing, the object of the sport is to neurologically impair your opponent, right? There's no other sport like it. In hockey, football, you still have to score points, but not in boxing. You win by impairing neurologically your opponent. So I found that would be a great challenge to try and make boxing safer. And I've worked with and continue to work with excellent people who understand that. So a lot of what we do in boxing is eliminate fights ahead of time based on their pre-fight examination. So we will bag them before they get in, especially if we think it's a mismatch. It depends on what you're doing. Now, even in MMA, you can get a hold on somebody and still win the fight without neurologically impairing them. So boxing was a particular challenge. And the reason I bring that up is because in 2011, DeMaurice Smith, who was then the executive director for the NFLPA, reached out to me and said, we're getting ready for our collective bargaining agreement, and I'd like you to come on board and work with us. Now, I'd never worked in professional football. I did work at the University of Connecticut at the time on their sideline. So I said, well, why me? I mean, I have no contact with this. And he said, because in 2009, you were named the Ringside Physician of the Year. And he said, we don't want our sport to become boxing. Yeah. Again, think about it. He didn't want his sport to become a sport where mothers don't want their kids to play. And in 2011, that collective bargaining agreement, so much of it was based on safety. Right away, when you hear collective bargaining, it's about the money. He didn't make it about the money. Also, think back then, the NFL back then was still working on the premise that concussion is not an issue in the sport of football. They would tell me that to my face in meetings, which were not very pleasant. But so we went in 2011 to where we are today in promoting safety. And the NFL Players Association continues to drive that position. So it's kind of a long answer to your question, but it's interesting how everything started linking together, especially with respect to the NFLPA and the insight of a brilliant man like DeMaurice Smith.
That's so, I mean, what foresight, right? To be able to see that coming and to address it as early as he did. I love that you've taken this on to work with athletes in so many different sports. You've worked with professional bull riders, you've worked with Coast Guard Academy, you've worked with WNBA. What do you love about working with athletes in particular?
Yeah, what I love is the fact that I know they're going to do what they have to do to get better. You know, there's this athlete mind, I call it. And it pertains to any illness. I've had patients with Lou Gehrig's disease. It's going to be terminal. And athletes take a different position. And no matter how bad it is, a brain tumor, Lou Gehrig's disease, they get back to the point of, okay, yeah, all right. Well, how do I get better? All right. They're not taking this thing that this is terminal, this is over. Never. They just want to get back to the gym as quick as they can and start working it out. And that's what I love, because they're going to listen to me. First of all, they know how to take information and guidance and digest it. Whereas other patients kind of, and many of these are former athletes, they're not even professional athletes, but having that athletic background makes them think, yeah, okay, I know what you're telling me, but all right, what's the plan for getting better? I need a plan and I'm going to follow it. And they do. And I think it adds to their longevity. It's that attitude. And yeah, that's what gets me going. Those are the people you want to work with.
Is that also something that makes it challenging to work with athletes?
Good point. Well, let me explain why. Okay. I'm laughing, but let me explain why. There are two types of athletes. There are employed athletes, right? So when I work with baseball players, football players, they go on the IL, right? They're injured. They go on an IL. They're still getting a paycheck. Then there are self-employed athletes, right? So combat sports athletes, the bull riders, cyclists, I'm sure, again, you're self-employed. Yep. You're paying your own way. You go down, nobody's paying your house bills, right? So, you have some sponsorships. So here's the rule. Employed athletes lie to me about half the time when they're ready to go back. Self-employed athletes lie all the time. Okay. Because it's no play, no pay. Right. I mean, so I really have to figure out, who's running some jive by me here so they can get back on the bike. Right. So you have to take that all into consideration. And especially with boxing. I mean, it's so funny. I go back to boxing because it's that extreme example, right? I'm sitting there witnessing brain injury. And I've learned a lot, because I've learned that the human brain is a very resilient organ if you treat it right. Right. So if they get hurt, as long as they rest it for a period of time, the brain will repair itself. It's when they keep going back and start sparring a few days later, things like that. So in those situations, you learn an awful lot about the athlete, but also, again, we said boxing, these are athletes who come from, when you look at the history of boxing, it's always people in the lowest socioeconomic level, right? Who have to do that. We look at these higher level athletes, but that's few and far between. There are combat sports events going on everywhere in the United States every day. And many are people who are down on their luck, may have just gotten out of prison, and are trying to make a few $100 by going in a ring and getting beaten up. So again, that's where you have to be really careful with a sport and advocate for the fighter.
Yeah. Yeah. I think the advocacy for the athlete is so big. And that's one of the things that I really appreciate that comes through in all of the research I've done, all the interviews, and of course, our work together. I want to expand on that for just a minute, because I think there are definitely the financial incentives, but also from a psychological perspective, you don't get to a high level of sport without loving the sport and really having committed yourself to it for a really long time. So there's financial risk, but there's also a really deep psychological risk, right? To loss of identity, and this idea, that you've put all of this time and effort into pursuing maybe your life's dream, and it's become your life's work. And the idea that you might need to take time out from that, or you might not be able to, enter the next race, or you might have to sit out the season. Those are not things that really any athlete wants to hear at any level.
Absolutely. So I think that's where the rehab piece comes in, I think.
Let's get into that. Let's talk about a high level overview of brain injury. I think most of our audience, they've heard of concussion, they've heard of TBI, traumatic brain injury, but let's kind of establish some definitions for the purpose of discussion. So is there a difference between concussion and a traumatic brain injury? And if so, what is that difference?
Okay, well, we'll talk about it. And I know you mentioned in your question you sent to me, I'm sure you'll want to give some disclaimer about treating injury and stuff.
Yes.
And
Yes.
obviously, I'm not going to treat anybody's specific injury over a podcast, but I think today, as we move through this, I hope to give every listener actionable information that will help them either with respect to their current brain health or recovery from a brain injury. I think that's our goal from that standpoint, and it can be done. So I really want to make that point. As a matter of fact, by the time we're done with the questions you asked, I think most of your listeners, they will know more than most physicians about a concussion. But we'll
That's
see.
wonderful and also scary.
Well, let's go right off the bat. You asked about concussion and TBI. So when you look at traumatic brain injury, we're looking at a range of injury, right? Mm-hmm. So the most severe traumatic brain injury is obviously a penetrating trauma, a gunshot, a shrapnel wound to the brain. That's the most severe. The most mild in that range is a concussion. And that's why some people refer to it as a mild traumatic brain injury. What makes it hard to diagnose is, as I said, it's vague. It's a functional disturbance. So it's not a disturbance where you're going to see something on a CT scan or an MRI or some outward sign. It's a functional disturbance. And to understand that, we need to take a step back again and look at the brain. What makes up the brain? And the brain is basically a network of wires. When I give a slide presentation, I show kind of like the traffic pattern, right? You see where it's green, it's red. Once you upset that network, everything turns red because things are not things are clogged up. That's a concussion. And the question becomes, can you get it back to working to where it was? And if so, how? And that's, I think, the important part of what we're discussing today. So when we think of a discussion, a definition of concussion, it is a syndrome, a group of symptoms that are transient. So it's transient neurologic syndrome as a result of a biomechanical force applied to the brain. Now, that injury could be direct, such as getting hit on the head, or it can actually be indirect, such as a whiplash type of injury, or something of that nature where the brain rattles within the skull. So again, that's the best working definition. Now, we used to say it was immediate and transient, and it doesn't have to be immediate. Usually, at the most, it would take at least 48 hours, okay? Often it's immediate, but sometimes you can see some delayed symptoms of a concussion or a traumatic brain injury. So we take that into consideration with the definition itself. The difference with athletes is that when someone hits their head in a car accident or falls down the stairs, you don't assume that they're going to fall down the stairs or get in another car accident. But when I see a cyclist, and I saw a mountain biker the other day, I'm pretty much assuming he or she is going down again somewhere along the way. So that's what makes the difference in treating athletes is you have to have this implicit understanding that, okay, this happened now. It may have happened in the past, but it's going to happen again if they're going to continue their sport. So that's what really distinguishes the treatment and definition of concussion when you get to an athlete, and as opposed to someone tripping and falling in a store or something of that nature.
That makes sense. One of the questions our listeners posed was, can you sustain a TBI without hitting your head? And before you dive into answer that, let me just share, I remember when I came to see you and one of the things I said to you was like, I wasn't sure if it was concussion because I didn't hit my head. And you said, oh, you don't have to hit your head. And I don't mean to answer the question for you, but I just remember in that moment, I experienced this whole montage of my career and all of these hard falls that I'd had and realized that I had been racing my bike for over 10 years with the, very inaccurate assumption that I had to hit my head to get a TBI. So with that, I'll let you answer the question.
Yeah, so we see that quite a bit. Also, so we see that movement. You have to understand. So when we think of the biomechanics of it, right? So there's these linear vectors going back and forth, and there's a rotational vector. And that's why in boxing or even in football, the most punishing blow is an uppercut, because you can impart not only a linear, but a rotational vector, right?
Oh,
So just think about that, because you don't need to have a blow to the head, especially in cycling, right? To have
right.
an impact where the bike suddenly stops, right? And you don't, all right? And there's this rotational and linear vector applied to the brain at high speed. So with that, you clearly do not. Now, another thing we often see is an association with similar symptoms to concussion, but they're coming from a neck injury. And you don't want to miss the neck injury. So we call that cervicogenic disease. Okay. So a headache and dizziness, right? So headache, dizziness, vomiting, the whole thing, but can be coming from the neck. But you don't want to make that assumption early on. Acutely, you want to get it worked up as if it's a concussion, but often we need to focus on the neck in terms of our rehab.
That's interesting. Yeah. So if you focus too narrowly on concussion, you might miss a neck injury that could, cause ongoing issues.
Absolutely. And we see that very often. We see that often in baseball, oddly enough, because baseball is the hardest sport to come back to after a head injury. And you could imagine why, and specifically hitting a baseball, because you have to have such good eye-hand coordination. You have to pick up the spin of the ball as it's coming and know when to react. And it's in such a short period of time. Just think, if that network is not working in its best situation, you're going to be in trouble. So often baseball players are the biggest challenge, and specifically hitting a baseball to getting back to their full participation.
That's so interesting. So one of our listener questions before we move on from this, they ask, what's the difference between an innocuous bump on the head and a concussion?
Great question. Because we've almost created a concussion paranoia out there, okay? So everybody thinks we've all hit our heads in the attic, right? You got up too quick. You were under a table doing something. There's a big difference between hitting your head and having a concussion. Don't forget, as we said, the definition of concussion is a syndrome, right? So it's a group of symptoms. Could be a loss of consciousness, but doesn't have to be, right? You could have nausea, dizziness, persistent headache. But the thing I look for the most, and this is where we're getting into, I'm going to make your listeners the smartest people in a sports bar, okay, right
Perfect.
now. Because here I am at ringside, right? And I'm watching a fight, and then suddenly I get up and end the fight before the fighter has gone down, before they're bleeding. Naturally, that's when everybody boos. But I'll tell you what I'm looking for. I'm looking at their feet. I'm looking at their feet, because if they develop unsteady gait, that means their feet are uncoordinated. So if you're watching a fight in a sports bar with your friends and you see a fighter go down and gets up, and he or she are just not feeling their balance, they're so-called flat-footed, that fight's going to end pretty quickly and not well. Because if they can't coordinate their feet, they also can't coordinate their hands. And now I potentially have a defenseless fighter. So I'm looking at their feet. The same holds true for other athletes. So when I'm on the sideline watching a game, I'm looking for three things. And I think, again, your listeners should bear this in mind. Even if you're a parent at a soccer game, we all should be observers, whether it's your team, the other team, whatever it is. The three things to look for are Is it taking the athlete longer to get up from the ground than they should? Did they need help getting up? And after getting up, going back to the huddle or playing, is their gait unsteady? If you see those three things, it's time to tell the coach to at least bring them to the sideline and ask a couple of questions to see what's going on. Now, you could see the same thing when someone gets the wind knocked out of them. You could see it in other circumstances. But again, the possibility of that person having a concussion is relevant. The other problem with this is, understand, when someone's been hit in the head, they're not the best informant, right? You've got an impaired informant. So you're trying to get information from someone who may have had some amnesia for the event. So that's what makes it pretty challenging from that standpoint. But those three things are key if you're watching an event, and especially if it's a children's event where you may not have EMS, you don't have athletic trainers. You know, as parents and grandparents, we all need to participate in the process.
I love that. Yeah. So a couple follow-up questions for you on that. One is, so with cycling, for example, there's kind of two scenarios that come up in cycling. One is during a competitive event and one is during training. Training is a little bit, and there's different constraints for each scenario. So in a competitive event, you actually do probably have more third-party observers. So you have, you know, team directors in the cars following the race who might either witness the fall or witness the aftermath of the fall. You have mechanics, you have other staff, you have other riders who can observe the athlete who may have fallen. But what's interesting about the gait is that once the athlete gets back on the bike, their feet are clipped into the pedals. And so you're not necessarily going to see a disruption in gait as they're pedaling if they do get back on the bike. Is that something, like, as a third-party observer in a race scenario, would you be looking specifically for, okay, I need to be really focused on watching this athlete get up from the ground? What would you suggest in that situation?
That's an interesting situation. So it's interesting because when you bring up cycling, we know that the first reflex when a cyclist goes down is what?
Get back on the bike as fast as you can.
Get back on the bike.
Yeah.
It may not be that easy for them to get back on the bike. So that transition is something to watch. Also, are they making good judgments? Are they performing the way they should? So in this case, again, you're not watching their feet, but by the same token, are they hesitant to get back on the bike? Meaning, are they scrambling to look for parts? Are they just not following the transition sequence that we would expect? Right? Because right away, they're looking around, they got the bike, they're getting ready to clip in. Is there that moment of pause where they're not sure of where they are or what they're doing? So I would look for that acutely in a cyclist.
Yeah.
That would be the best way to look at that.
That makes sense. The other thing that's complicated about a race scenario, and I'm speaking specifically about road cycling, that's where
I gathered that.
My experience is. This can hold true for some mountain bike races too, but they don't stop the race, right? So if there's a crash, the expectation is that the race keeps going. So if somebody hits the deck, it's up to them to make the decision to get back on the bike and get back in the race. And the longer they take to make that decision, the higher the chances that they're not going to, be able to reconnect with the race and participate. So the athlete, they are 100%, I got to get back on the bike as fast as I can. That adds an element of complication. Like there's no, we don't get to go to the corner of the ring. There's no bench where we can sub somebody in. How risky is it to keep going if you have sustained a concussion versus stopping in that scenario? Or is there a way to generalize that even?
Interesting. It's an interesting question because, well, let's get to the physiology because I think that will explain it a little bit better. When we think of a concussion, it's a cellular change that we've been able to demonstrate. So what happens is there's a breach in a nerve cell wall in your brain, like many of them. The nerve cell is kept in balance by calcium being outside the cell and potassium being inside the cell. When you breach that wall, calcium rushes in and causes swelling and damage to the cell. So to use an analogy, if you had a leak in your basement, there's a crack in the wall, right? Water's rushing in.
Right.
So what you have to do now is pump that water out as fast as you can. It's the same thing the cell is doing. It has these little pumps in the membrane that require energy in the form of ATP to drive them and get the calcium out. What really happens is it's an energy deficit. So when you have this concussion and all this going on, your brain demands more oxygen, more circulation at a point where it's getting less. So what you're dealing with in the brain is an energy deficit between the need for energy and its ability, your body's ability to produce that energy. So what will happen in the most extreme case, right, is you lose consciousness. Your brain is saying, I can't keep up. We're shutting down and rebooting this thing. So that's what's happening. Now, when we talk about people who have, the second impact syndrome or things that get worse, if you can imagine that you have this crack and you're trying to repair it and you go back and you don't take yourself out of the game and you get hit again. Now you've got another crack, right? So you've overwhelmed these cells with swelling that can cause so much brain swelling and eventually end in death. Now, to get back to your analogy, let's think about it. So you've had this head injury and you're getting back on the bike. So now your body is trying to repair the brain. At the same time, your muscles are demanding blood supply. Something's going to give, right? Something has to give. So what will happen is your neurologic symptoms will worsen, whether they be headache, nausea, incoordination, any of the things I talked about. And especially confusion, okay, because your brain can't work properly and your body can't work too well either. So you're really at this energy. So it becomes readily apparent that if that's the case where you've had a concussion and you're going to try and keep going, you're not going to be very successful. Can't be. So
that makes sense.
Hopefully the athlete listening to this podcast will understand that, because now you've amplified the damage. So where you might have been able to shut it down and come back the next day for the next stage, right? You may be down for a week now. So you really have to understand the brain and some of that basic physiology. And it's something athletes can understand because they understand oxygen, right? Everybody's measuring their VO2 max, right? Everybody's got a ring or a watch. They're into those numbers. Well, those numbers don't lie when it comes to the brain either. So,
yeah. I think your point about being out for, the rest of the day or a week versus, compounding that into weeks, months is a point well taken. And I can, I'm thinking back on my career, how many times I hit the deck really hard. And my thinking in the moment was, the concussion that I sustained when I came in to see you, I'll never forget. I hit the deck really hard. But my first thought
was a gravel race, right?
Exactly. Yeah, that was a gravel race.
Listen, you have the rare distinction of being the only gravel racer I've ever seen in my career. It's true.
That's funny. So I hit the ground and I remember thinking, okay, I didn't hit my head, and I did this kind of quick head to toe assessment and thought, if I can get on my bike, I should. And my follow-up thought was, if there's something really wrong, I'll deal with it at the finish line. Not thinking that the time between me getting back on the bike and the finish line could be that most important, time window of either exacerbating an issue or giving me the opportunity to, heal and rehabilitate faster. So this is, to any athletes listening, I think learn from my mistakes.
Well, it's the same mistake of many. I mean, and it's part of that athlete mentality that we talked about.
Oh, yeah. I mean, I think honestly, I think I must have been in shock. And in that race, the reason I stopped wasn't because of cognitive impairment. It was because I had hit my knee in the fall and my knee started swelling. And I thought, well, and again, this just goes to show my lack of understanding in the moment. I saw the knee swelling and I thought, well, it's not worth it to me to finish this race and have a lifelong knee injury. So I'm going to stop. But it never occurred to me to think it's not worth it to me to finish this race and have a lifelong or, season-long brain injury. So I'm going to stop. And that just speaks to the visibility of it, right? Yeah.
Sure.
The experience and, just general social awareness and cultural awareness within sport, I think makes a big difference. So this is one of the questions that came up a lot, which was, how can I even tell if I have a concussion? So let's set the racing aside for a moment. A lot of people ride for fun, or, even as a competitor, I spent most of my time on training rides, not necessarily in races.
Sure.
Where I may be riding alone. I don't have, a team doctor following me, and maybe I hit the deck, and it's likely, if I do have a concussion, that I'm impaired. Is there a way that somebody could self-assess in the field, so to speak?
That's a tough one because you're already impaired, right? So, you'll know. I mean, when your head starts pounding, you'll know something's wrong. If you can't remember the circumstances for which you went down, which retrograde amnesia is not uncommon, you're going to suddenly start to realize this while you're on the ride. Or you're going to note that you're making stupid mistakes, things that should be automatic, like shifting, right? I mean, for a racer, shifting is automatic, right? You know when you have to shift. And if you find yourself in the wrong gear or just things aren't working that smoothly after you've had a fall, it's time to reassess. But again, it's hard to self-assess after you've been impaired. That's what makes it difficult. But I think that as you get back on the bike and you're riding and you're saying, something's not right here, it's time to shut it down.
Yeah. And so at that point, let's say whether you're in a race or you're in a training ride and you've decided something's up, I need to shut this down. What are the steps for seeking treatment? Who should you be speaking to, and how do you follow up on that?
So there's a succession of things. So first of all, the question becomes, do you need emergency care in terms of the level of injury? Do you need a CT scan? Did you hit your head directly? So the initial assessment is, do I need to get to an emergency room? Do I need to get that urgent care? If you've been cycling at high speed and you hit your head, you better get to the emergency room.
Right.
And I almost hate to say this, but in many emergency rooms lately, they've been hesitant to do CT scans. They say, well, the radiation is minimal. And I have a very low threshold in the case of an acute injury to get a CT scan because it gives you so much information. And you remember we talked about this range of illness, right? So, when you're down here at concussion at the lower end, getting a CT scan isn't that big a deal. But what you don't want to miss is the other end and the so-called subdural hemorrhage or hematoma or epidural hematoma. Now, the epidural hematoma is every person's nightmare, every physician, every athletic trainer's nightmare. And to use the analogy of Natasha Richardson, that if you've heard her story, and I've had a similar story in the last few months where I was called actually by a law firm of all people. And it was a situation where a young man hit his head in a soccer match. I think it was a head to knee collision. They were in another state and the athletic trainer assessed him. They didn't put him back in, but dad was going to drive him home rather than have him go to a hospital or something of that nature. And on the way home, he started to decline rapidly. And father had enough sense to get him right to an emergency room, and he had an epidural hemorrhage. He would have died really.
Oh my
And the
gosh.
fact that he's still alive competing is fairly miraculous. In the Natasha Richardson case was, she had been skiing, hit her head in Canada, and went down, saw the EMS people. They wanted her to go to the emergency room to get a scan. She refused. The ambulance actually came to the mountain, and she still said, "No, I'm feeling fine." Goes back to her condominium and dies. So there's this clear period where everything's back to normal, but there's this hemorrhage coming from an artery in the brain that eventually often leads to someone's total demise. So again, I have a low threshold for getting a CT scan in those situations. Now, outside of emergency care, seeing your primary care physician is fine, but it's, you have to understand also somewhere around 90% of all concussions get better in 2 weeks, right? That's the beauty.
That's really
Everybody
encouraging.
well, here's what it is. Everybody's got a concussion clinic. I mean, we got everybody treating concussion, right? And I'll probably get I'll get calls, but I mean, there are dentists who have concussion clinics, chiropractic concussion clinics, psychologists have concussion clinics. I mean, you don't have to be a Phi Beta Kappa to take care of something that gets better in 2 weeks. Okay. So there is that period of time. The real issue comes in is when it's not getting better. What I tell people who have not gone to the emergency room is what we like to do is observe somebody for a period of hours, 4 hours or whatever. Or if they go home, make sure they're being observed, because if they're not getting better or getting worse, it's time to get to the emergency room.
Right.
But in the long run, seeing a neurologist who has expertise in seeing sports injuries makes a big difference because of the way we approach the brain from that standpoint. But again, primary care sports people do a great job of it. They see a lot of concussion. You want to see a doctor who sees a lot of concussion and athletes, as opposed to just seeing concussion in the legal arena, for lack of a better term.
Yeah. So one of our listener questions that's relevant to this is why is it that most doctors are not trained in the area of concussion? So I'm curious about that, because I do think that there does seem to be a lag between kind of the latest research and clinical application. And if somebody is seeking care, not emergent care, but through maybe a GP or somebody, why is it that most doctors aren't trained in this area? And then a follow-up question to that is, how can people advocate for themselves to get to see somebody who would have this background and this perspective?
Well, myself and my daughter Stephanie are always available in terms of referral. We know where there are these pockets of people who do it better than other people. It's hard because it's a complicated. It's not that simple. Even though I said it gets better in 2 weeks,
yeah,
the ones that don't get better are difficult to manage. So the question becomes, I think we've made great strides with physicians recognizing a concussion. And if anything, the pendulum has swung in the other direction in terms of recognition of concussion. But by the same token, I'd rather it go that way. I'd rather people have a low threshold for it, and then we clear it up. Because we haven't even talked about the features that make it worse. Like, for example, if someone has migraine headaches, guess what's going to happen if you hit your head? Probably going to get a migraine. So are we treating migraine now, or are we treating a concussion? People who have depression. You brought up the idea of someone who may have some baseline depression now is taken away from the one thing they love, their sport.
Right.
What do you think is going to happen? They start feeling more isolated. That's why I like to have my athletes, even after they have had a concussion, still working out with their team. Whether they're riding the bike on the sideline, they have to be part of the action. You don't want to just leave them isolated in a room or doing something else, because they're gonna fall into a depression. The mental health aspects of it are a whole nother thing, probably a whole nother podcast. But certainly something that you need to take into consideration. And the treatment of concussion, it changes all the time. I had someone come to me in a situation where I was giving a deposition on a case, and the lawyer said, well, doctor, we have it here that in 2015, this is what you said. And I said, listen, this business changes every day. What I said in 2015 certainly doesn't apply to what I know today. I mean, this is science. I mean, but lawyers think that once you've said it, or they have a record of it on a blog or on this podcast, that it's suddenly set in a tablet somewhere. So anyhow, it's going to change. And I think that's hard for a lot of physicians unless this is something you do a lot.
Yeah. Yeah, that makes sense. And that speaks to the importance of seeing a specialist who has this experience and who is on top of that. So what are some things that you would look for if somebody came in to see you with having had either, direct blow to the head or a hard fall? What are some of the things that you would be looking for in terms of diagnosis?
Well, a couple of things. First of all, one of the key things in neurology is to just sit and listen to the patient. Just listen to them, because typically they're going to paint a picture. Now, the visit takes a long time. I mean, you got to be willing to sit there for an hour, because you've got to get out of them exactly what has happened and what they're describing. You also need to go back into their past history to have a good understanding of that person. Don't forget, I've never seen this person before. I'm not their primary care doctor. I don't know what else is going on in life and what their other problems have been, what their genetics are, right? So a lot of times getting a concussion will provoke the first migraine they've ever had in someone who has a strong family history of migraine headaches. So again, I often say, if you've seen one concussion, you've seen one concussion, and that's truly the case. And that's why I resent these protocols, right? We've got protocols.
Yeah.
And maybe resent is a strong word, but understand, a protocol is designed for research, right? So that everybody involved in a research project does everything the same way. That's what a protocol is. So what we've done is we've created protocols for people who are not fully trained as physicians or even as medical personnel, to say, okay, you hit your head, this is what you do to get better, right? Stay away from screens, no noise, you go to sleep, you need to sleep this minute. Doesn't work. Every person is different. So we have to recognize that right from the beginning. Now, having a protocol, even to get someone back to their activity, is different, because it's different based on their sport. So we've tried to simplify things and maybe messing it up, because a lot of times I'll see an athlete who's on this protocol and they're out for 2 weeks, and I'm like, you can go back today. This has got nothing to do with hitting your head. You've got a migraine headache. Here's the medication. Go back and play. Or it's something totally different. So I think people are surprised that when they come to see me, and I noticed this was with the professional bull riders, right? When we started seeing them, I think there was this feeling that they're sending me to see the neurologist. He's going to end my career. So they would fly them here to the University of Connecticut. And the first two folks we saw one fellow who really, he thought his headaches were from hitting his head a lot. They were actually migraine headaches, and we treated his migraine. And the other fellow had ADHD and never knew it. He was always the slowest kid in the back of the classroom, and he couldn't focus. So we treated both of those athletes, and they rose to being among the top 10 in the world in their sport. So suddenly, we started getting the feedback that, hey, you ought to go see these folks because I got better, right? So there's a brain health factor here. And again, misinformation. So there are a lot of different aspects to seeing patients with this type of problem from that standpoint.
We'll hear more from Dr. Alessi after this quick break. We want to make this podcast financially sustainable and need your help to keep a good thing going. Sign up for a Be a Good Wheel membership on Ko-Fi and get access to extended guest interviews, bonus episodes, and Be a Good Wheel gear. Monthly memberships start as low as $3 per month. Go to ko-fi.com/beagoodwheel to join other members who are supporting the show. That's ko-fi.com/beagoodwheel. And now back to our conversation with sports neurologist, Dr. Anthony Alessi.
I love your quote that if you've seen one concussion, you've seen one concussion. And I think that what people are trying to achieve with the protocols is, in that crucial moment, like, what do we do? And I know in cycling, the UCI, the Union Cycliste International, or International Federation, uses the SCAT5 protocol. But
Sure.
This is not something that you can do roadside until you've decided that the athlete is coming out of competition, because it just takes too long. And I think, at this point, organizations feel like they have to have a protocol or they're not fulfilling their duty of care for their athletes. So what would you recommend for coaches or trainers or staff members who want to fulfill a duty of care for their athletes? What is the better option? Is it to recommend that they see a specialist? Because to your point, the protocol is generalized. And what you're saying with if you've seen one concussion, you've seen one concussion, is each case is different and very specific to the individual. So how do we balance those two?
So of the protocols that are out there, of the testing that's out there for non-physicians, the SCAT5 and SCAT6 are the best. The problem we get into is when we start administering the SCAT in the face of acute injury. Because don't forget, you're asking somebody to remember 5 things forward, numbers in reverse. They're going to do things that they really can't do. If you think it's a concussion, so that helps you if you're not sure it's a concussion, right? So that when we look at it, we look at concussion, we have possible, probable, and definite. When you've got a definite concussion, why do you need the test, right? You're going to shut them down, right? If it's possible, you're going to assess other things to see if it is. And again, that's where a physician comes in to help you to say, yeah, you're good to go. I mean, that's what I do on the sideline is I help determine if an athlete can go back into a football game or other event. And the probable is where it helps you. But doing it acutely doesn't help a great deal. The thing we have a problem with are these tests that are designed to say, okay, you got a green light or red light or whatever. I mean, we had the impact test. I think people still require the impact test, but the impact test looks at a very narrow psychological presentation in terms of cognitive ability rather than the entire patient. I'm often called upon to assess an athlete who has not passed the impact test but is ready to go back, right? Physically, mentally. And what's happened is they're so nervous about taking the impact test that they take too long to answer the questions. So I have to kind of overrule that part of it. And I can do that. So that's where it becomes kind of an art in terms of seeing the patient and trying to treat them. And there are a lot of different tests. To just base it on psychological tests, I see that all the time. So they administer a variety of psychological tests and determine the athlete's not ready to go back. But what did the psychological test look at before? Okay. Did you have a baseline? And often that's not the case. So you have to work off of, there's no one test that tells you the best. It's really medical judgment for a medical practitioner, not just a neurologist, but a medical practitioner who has experience in working with patients like this.
Yeah. Let's say a coach assesses an athlete. They've determined to take them out of the sport, at least temporarily, to seek treatment. One of the things I hear a lot is rest, stay off screens, sit in a dark room, especially in the first 48 hours. How does that advice track with your experience?
Totally wrong. And I'll tell you why. And believe me, that lawyer may have quoted me correctly in 2015, but here's what we have learned. When we think of the human body, right? The human body loves homeostasis, right? If the human body could wake up the same time every day, go to sleep the same time every day, eat the same thing every day, your cells are happy campers. But we know that's not practical, right? We all have to deal with things, right? And when you're a cyclist or any other professional, you have to deal with travel. You have to deal with workout schedules. But just think about it. Your body loves homeostasis. So we've taken this athlete who's performing at this level every day, and they hit their head, and we bring them down to zero. Zero. Lock them in a room. It's dark. No stimulation. What does that do to homeostasis, right? Screws it up pretty good. So the studies that have been done by Thomas and other researchers have shown that the quicker you get an athlete back to some level of aerobic activity, so instead of dropping them down, just bring them down to where they can tolerate the activity, they will return to their sport in half the amount of time as someone who went to zero. It's very interesting. So what do we mean by that? And what we mean is tolerated exercise. So if they can get on the stationary bike the day after an injury without throwing up or maybe get a slight headache, fine. If they could deal with the slight headache, get on the bike. You don't have to get your heart rate up over 100. We just want you moving, okay? And we'll work from there. So I like to get athletes back into some aerobic fitness activity within 48 hours of a head injury, even if they're having symptoms. So it doesn't mean you got to shut down until all your symptoms go away. No, you go back to the activity tolerated. Same thing with screens. Some people can't stand looking at a screen after a concussion. Others say, not so bad. I can tolerate this. I can watch TV. Some people just can't take bright lights, so they wear sunglasses, okay? But so everybody is different in what they can tolerate. So again, that's where a protocol doesn't fit. You need to understand the athlete. But specifically for athletes, we can't have their level of activity crashing like that. That's going to work against us in the long run in getting them back.
That's so interesting because that seems counterintuitive when you're thinking about what we talked about earlier, when you have that cellular damage happening in the brain that's requiring this huge amount of energy to address. You're trying to fix a leak in the basement. It's taking a big amount of energy. Why is it important to go back to some level of activity rather than rest completely, given that energy demand that's happening?
Well, because the energy demand, that analogy is in the acute phase, right? So there's an acute, subacute, chronic, right? When you're talking a day later, you're into the subacute phase. That's been repaired. If you didn't repair that crack by then, you're in big trouble, right? So that has been repaired. That's in the acute phase of injury, which is typically in the first minutes to hours after injury. Now you have to deal with the subacute phase and the chronic phase of recovery. So even if you take that narrow window of 2 weeks, right, you've got that period to work with to get back. So somebody who it takes 2 weeks versus 1 week, that aerobic exercise could make the difference.
That's really interesting. Does it make a difference in terms of like blood flow, lymphatic drainage, in terms of the healing and the recovery process?
Absolutely. Absolutely. That's where the level of activity comes, right? Because your body as an athlete, you're used to a certain amount. You're used to, blood pumping, right? So to start shutting that down and then think, okay, my headache's gone. I'm ready to get back on the bike. You're like, what happened here?
Yeah. I remember one of the things that you said when we worked together was that concussions can cause a whole suite of different types of symptoms, constellations of which will vary, according to the individual. So what are the types of treatments available to address some of those, I don't know if we want to call them symptoms or, functional limitations that arise as the result of a TBI? Because it seems like there's been a lot of progress on that front as well.
Yeah, great question. Well, first of all, you have to narrow things down to where the biggest symptom is. So if the symptom is cognitive, I often incorporate a neuropsychologist. I have an excellent neuropsychologist who works with athletes and can give me an objective measure of, is our problem here related to hitting your head, or is it related to some other factor that has become worsened, like a certain level of anxiety that may have now become amplified after this traumatic injury. In which case, we want to treat the anxiety, right? Because we want to get that under control, or we're never getting back to our sport. So that would be the cognitive aspect of it. Some people, their predominant issue is headache. How is the headache behaving? Is it more of a headache coming from the back of the head, radiating forward like occipital neuralgia? In which case, you can do some nerve blocks that would work wonderfully for that type of headache. Somebody with migraine, right? So now you have to get more aggressive in treating their migraine. You also want to look at, as we said, your neck. The vestibular symptoms are often very difficult, right? And that's where that sudden dizziness, if you're turning to the side. Imagine having vestibular symptoms and trying to ride a bike, right? It's not going to work. Right?
I don't have to imagine. I remember.
So we have to, right. So we have to work with a physical therapist who's specifically trained in vestibular rehabilitation to reprogram that connection of moving your head and your brain knowing it. So again, it becomes very specialized to what your symptoms are. And if you're already having symptoms and already on medication, maybe altering those medications and working within the scope of that.
Yeah, I remember, I think I just told you, I just feel off. And I was actually embarrassed to share that because it felt like I felt like as an athlete, I should have the self-awareness and the body awareness to give you a much more specific and less vague suite of symptoms to describe how I was feeling. And that was as specific as I could get. And I think a lot of that did have to do with that vestibular and proprioceptive system, because I literally just wasn't exactly sure where I was in space. It wasn't that I couldn't walk and function, but I just felt off. And it was a really odd, vague, nuanced sensation that really only became clear with more time.
It's interesting. So many people come to me and say, I think I'm crazy, and they present symptoms that make total sense to a neurologist. So I want to encourage people not to be intimidated to share, I'm a little off. Okay, well, let's expound upon that. Or, I feel tingling. Like they say, well, I feel like something's crawling on my arm. Well, that's called a paresthesia. That's a distortion of sensation. That makes a lot of sense to a neurologist. Whereas, you start at 2:00 in the morning, you think, wow, man, I am really way out. So, you need to share those symptoms with your neurologist when you're doing that.
Yeah, I think it's funny that in my head, it just seemed like such a weird thing to say. And to you, it was like, oh, that's actually a really helpful diagnostic. So have you observed or are you aware of differences in either the experience, diagnosis, or treatment for concussion between men and women according to age? Are there any kind of general trends or patterns along kind of demographic lines that have emerged?
Yeah. So in general, it takes longer for children to get better. And that's why we're so cautious with children, because their brains are not fully developed really until you're in your early teens. That's why, playing tackle football for a child under the age of 14 doesn't make any sense. Just does not make sense. Some parents think that, this youth football, tackle football, is the beginning of an NFL career. And typically it's the end of an NFL career because they'll have injuries that will prevent them to getting to a higher level. Whereas now I'm so happy to see so many people playing flag football. And even they wear helmets for flag football. My grandson started playing. I couldn't believe it. It's like a headband with a cushion on the back because they're going to fall back. But, Archie Manning never had his sons play youth football. Tom Brady didn't play youth football. They played other sports and built those skills. So I would encourage parents to stay away from that. It takes children longer to get better for the reasons that their brains have not fully matured and could have greater implication in the long run. Women take longer for some reason, and we don't know why. We don't know if it's a hormonal difference or what it is, but often women will take somewhat longer to get better. Again, not
That's
sure.
interesting.
But people with ADHD, depression, migraine headaches, again, these other ongoing symptoms will also take longer to get better.
Yeah, that was really interesting. In my case, you ordered the neuropsych evaluation. I went in, we were looking for, any cognitive impairment as a result of the concussion, and come to find out that I had undiagnosed ADHD, which was incredibly helpful and life-changing for me. And I think that, one of the things that we found in that was, as you had mentioned, that I knew that I had previously struggled with anxiety, and it definitely amplified with this injury. And that was something that I was able to work, with my therapist on, and super helpful. And I'm so happy that that's something that you brought up, because I think it is such an important component, not only of the treatment and the prognosis, but just, mental health is a really key factor in basic well-being, but also performance for athletes. So,
yeah, absolutely. Absolutely.
Yeah. And I'm curious about the age. So I would have thought that it would take kids less time to recover. Is there like a U curve with that? Is it just in terms of the brain development into early adulthood? And then do you kind of have like a plateau in terms of prognosis? Does it take longer to heal as you get like in advanced age?
I'm laughing because there is a curve. It takes longer. And then when you hit 40, it starts taking longer again. Okay. So there's this cycle of life where we end up as children again. As you get older, it also takes longer. So recovery is best when you're in that window. I think more than anything. And that's basic physiology.
So what are some, aside from age, what are some factors that affect prognosis or might either shorten or lengthen the time that it takes for somebody to feel normal again or to return to play?
I think their underlying health overall. If you're taking someone who's in phenomenal condition, there are always those other factors in terms of it. So I think good general health, and that's why I like eating habits, because what are the basic things again? Well, are you getting enough sleep? Are you eating a good diet? And are you hydrating? This isn't rocket science, all right? I mean, it really isn't. We got to get back to that homeostasis where you're meeting your body's demands. And so that's why, people trying to sell you the next great powder or treatment or device can sometimes be frustrating overall, because you just need to get to the basics and treat your brain right.
Overall health is important for prognosis. Age can affect it. Why is it, this actually is another question that comes from one of the listeners, so I'll just read it verbatim. Why do some athletes say recovery lasts months and months and others a week or two? What are some of the things that kind of feed into or influence these wildly varying recovery times that we see?
So I think it's based on what you're working with to begin with, in terms of, are there these other factors? As I said, you can imagine someone who is now going through a period of depression after their head injury. You've got to get them out of that phase. So that could take a while, just looking at it from a psychological standpoint. Someone who is having these neurologic symptoms, but as a result of a neck injury, until you wrapped your arms around that. Some people, their vestibular symptoms last a long time, and the vestibular therapy takes a while. So it really depends on the degree of injury in terms of how long it will take to recover. So there's no way to predict.
Yeah, that's good to know. So one of the things I was curious about is my understanding, and I could be wrong here, so please, this is a question for you. My understanding is that in the peripheral nervous system, neurons can regenerate, but in the central nervous system, brain and spinal cord, damaged neurons don't regenerate. Is that still what the science is telling us?
Absolutely not.
Huh.
Interesting.
Ooh, do tell.
I'll use the analogy of stroke, right? Used to think if someone had a stroke, right, they clotted off a blood vessel going to the brain, a piece of the brain dies. And They would lose all function.
Hmm.
And that has changed a lot. Funny story, and I almost hate to admit this, but I've learned the most about stroke from my mother-in-law, who's now deceased. God love her. When I first finished medical school, I knew everything, right? Everybody does when you first finish. And my wife's uncle had a stroke, and he couldn't move one side of his body. My mother-in-law was a nurse, old school nurse, old school, wore the hat, starched whites. She would go to that rehab facility every day and make him squeeze a ball. And I'm telling my fiance at the time, and I don't know what she's doing. I mean, the guy's got dead brain. I mean, nothing's coming back, right? Fast forward 40 years, right? And we understand now that certainly there is an area of dead. If you think of a bullseye, there's probably some dead brain there. But there's this other ring called the penumbra. And this penumbra are cells that can either live or die. And the way they live is by getting them to exercise.
Interesting.
Because that uncle made a full recovery. This guy went from not moving anything to going back to actually work. I mean, he was retired. He was back on his boat, lived absolutely you would not know he had a stroke.
Wow.
So, right. So that's why when people have a stroke, we want them rehabbing again within 24 hours. We want them trying to walk. We want them trying to squeeze. Some people actually take the person's good arm and disable it, right? They disable, they put it in a sling and just force them to use that paralyzed arm, no matter how hard it is to move, to get that penumbra back. So again, my mother-in-law was right. But for non-physiologic reasons, it just took us a while to catch up to her. And that's the beauty of neurology, is that how much we're learning. So stroke, the treatment of stroke has just changed dramatically. By the same token, after you've had a head injury or even a concussion, do you have dead brain? Probably not. Now, even if you've had a hemorrhage, again, there's still this penumbra around it that can recover. So you've got to get on that. So it's totally changed.
Because I mean, when you look at other tissues, I mean, I'm thinking about, bone growth remodeling, skin remodeling.
Sure.
In many other tissues, the remodeling process is stress to the remodeling is actually really beneficial for that remodeling process, because especially with bone, it's going to grow stronger under stress. And I didn't realize that it was similar. I mean, I'm assuming that this, I'm drawing into that analogy. Thank you.
You're absolutely right. I think that's a perfect analogy, Amber. I mean, that happens in the brain.
That's so cool.
And what happens also is, in addition to that penumbra, remember, if we go back to the analogy of this network and traffic, right? What happens when you're stuck in traffic? Well, you find another road to go around it. The brain does the same thing.
Yeah.
So we used to think the old phrenology, right? Your speech center is here. And once you've affected that, you've lost this, okay? Not necessarily, because your brain can now remodel and start using nerves from other areas, other nerve cells, to recover some of that speech. May not be perfect, but it'll recover. So again,
that's amazing.
That network idea globally of how the brain works is perfect for this.
And I want to frame this with the caveat that this process still requires a lot of energy. So this isn't a situation where you're going to go out and train full gas and hammer and all of that. That's not what we're talking about by exercise or stress. Allowing yourself to bring that level of training stress down so that you can, divert that energy to healing, but maintain some low level of light, low intensity aerobic exercise. Am I characterizing that correctly?
Absolutely. So even if we take the analogy of hitting a baseball again after a concussion, right? You don't just go in there and start hitting fastballs, right? So we have them hitting off a tee, right? So to gradually get that skill back again. again, that remodeling. We've gone from a concussion course to an entire residency in neurology right now. So we're on a roll. Everything you want to know about neurology from Alessi in 2 hours.
This is phenomenal. It's going to be so helpful because there are so many just, even like I've mentioned, misconceptions and assumptions that are, either were true 5-10 years ago and are no longer. So
yeah,
it's awesome. So before we move on, one of the things I want to just highlight is we talked about exercise, screen time to tolerance, and that's a very subjective term. And when it comes to athletes, especially cyclists, I'll say, I think you could make a strong argument that the sport of cycling really comes down to training yourself to tolerate more discomfort than the competitor next to you. So this is something that cyclists are really, really good at, is tolerating discomfort. So when you tell a cyclist or an athlete, and I'm sure this is true for many sports, when you tell an athlete that they can exercise to tolerance or they can use screens to tolerance, what would you say to them to ensure that they are safeguarding and not overriding some signals of discomfort that they should maybe listen to?
One of the hardest things most human beings have is listening to their body. And we say that a lot, right? We say that with mindfulness training, we say that psychological training, but we certainly need to do that with physical training. So when I think of cyclists, rowers, okay, competitive rowers, okay.
Great example.
Right. So these are athletes who train themselves to endure pain. Marathoners, same deal.
Mm-hmm.
So you have to listen to your body. And I think most athletes know what I mean by that. You know that when your performance isn't where it should be, after an injury, it's time to dial it back. Because it's not going to get better. If it's not a no pain, no gain situation. We know it's no pain, no gain because that's what you do when you're training. But after an injury, you have to really listen and look at your training, right? Look at your data, right? You're looking at your watch, you're looking at all the different things you do. And if those numbers are just not there, then it's time to dial it back and wait. It'll get better.
Yeah.
Just wait.
Yeah. And it seems like the sooner you can make that decision, potentially the shorter your recovery time could be.
The same with everything. Same with a knee injury. I mean, we're not, this is not high level psychodynamics here. That's the way it is.
It's not rocket science.
Yeah.
So one of the questions that we got, it connects back to, I'm fascinated that there is the possibility for neuronal regeneration in the brain. That's not something that I was aware of. And this question comes to us from one of our listeners. And the question is, what is the biggest change in the scientific community's understanding of concussions in the last 10 years? And how was this discovered?
I think probably in the last 10 years, as I mentioned, the work by Dr. Thomas and several other doctors about getting people back to aerobic activity is probably the biggest change. I think the other change is the fact that we have recognized that when examining someone, it was a good point, when you're examining someone, doing what we call visual ocular motor screening. So we know that of those networks we talked about, probably the most complicated is coordinating vision and motion because it takes so many connections in the brain, not just in the eyes, occipital lobe, brain stem, cerebellum. You've got so many connections. So with vestibulo-ocular motor screening, we have somebody do this, looking at a dot, doing a variety of tests to see how their eyes coordinate with movement. Mm-hmm. I think that part of the examination has changed the evaluation of concussion a great deal because if someone is having some subtle symptoms, you start stressing them, moving their head like that. and they're holding on to something. So you know what you've got.
Mm-hmm.
So again, that part of the examination, I think, has changed it, I would say, in the last 5 years. So we're learning quite a bit from as we start to do different tests and look at different situations.
What are some of the constraints in terms of conducting research in this area? Because I imagine it's not exactly ethical to recruit human subjects and induce concussion or TBI. So it must be really difficult, I imagine, to conduct research that is relevant to human systems or human systems in vivo. What are some of those constraints, and what are maybe some of the types of studies or experimental designs that give us the best information?
Well, my daughter Stephanie's involved in a project now she started actually looking at high school football players before they play football in high school, doing baseline examinations, and now following them throughout their career. So if they get a concussion, reevaluating them, comparing it to their previous exam, and seeing how their exam progresses, how long it takes them to recover. So I think clinical studies such as that are helpful.
Mm-hmm.
Whenever you can do a controlled study, and this comes into when people are looking at new treatments, various devices, and things such as that, again, you want to make sure you're doing controlled and blinded, if possible, studies where you're comparing apples and apples to see if that device or that intervention changes things. And in some respects, things have changed. I'll use the example of people are hearing about the Guardian cap, right? The Guardian cap was a football device, right? It looks like a pillow put over the head. And athletes say, this looks silly. And, at first, it was one of those things where I didn't have enough information to recommend it or not recommend it to a team. Teams were using them. You can't use them in a game. So the National Football League Players Association got together, and what they did was they looked at athletes using this and compared it to athletes not using it. So they had whole teams and came up with the finding that it did reduce concussion in certain players. So in the sport of football, we have decided that everybody looks the same. Everybody has the same injury. When you look at football, it's a lot of different skills, right? So we all saw the Tua injury where he had multiple concussions. The quarterback fell, hit the back of his head. So what we finally figured out is you need to design different helmets for different positions because they're going to have different injuries. So the Guardian cap works very well for linemen. Doesn't necessarily work very well for safeties and speed or skilled athletes because it adds extra weight to the helmet on the neck. So we were seeing athletes come up with neck strain. We saw some of that at the Coast Guard Academy. So again, these athletes who have to run quickly or catch a ball now have this extra strain on their neck. Which brings us to the point, if people want to try to resist concussion and avoid concussion, the best thing you can do is build up your neck, right? To avoid that extra motion. So from that standpoint, so with the Guardian cap, it's something I couldn't recommend or not recommend, but now I feel like we have enough information to say, yeah, if you're a lineman in practice, it's worth using from that standpoint. So the data kind of change things as we approach things. People always ask me about supplements. Is there a supplement? And you brought up the creatine. But what we do know is magnesium and vitamin B2 after a concussion. For some reason, if headache is the predominant symptom, that will often help. So a lot of the commercial things people are selling these days are basically magnesium and vitamin B2. So I do use that in athletes. We have found that to be effective in looking at studies.
That's so interesting. So a lot of our audience are very proactive. They're keen to understand the latest either because they're coaches or their parents. They're highly educated. They're not shy about going to PubMed, for example, and looking up studies.
Sure.
So where are some good sources for people to keep tabs on What are the latest advances? What are the latest changes in our understanding of the state of the science?
That's a good question. I think, it's hard, but I think in the neurologic literature, we're seeing more and more of it in the sports literature. But, these studies are ongoing. The biggest study is going on was, again, funded by the National Football League Players Association, the Harvard study. That has been an ongoing study that looks at a lot of different aspects of football injuries. So I don't have a single source for you on that. I think you'll see things coming up even in the popular literature. But again, it's worth asking someone who is a trusted resource, an athletic trainer. Again, they're keeping up with it as part of their continuing education. So if you hear something, go to a trusted source and say, hey, I read this. Does it make sense? Before you start engaging in it or spending a lot of money. Let me also explain. There are a lot of people making a lot of money on things because, it's a cash payout and, you may not get the results that are being promised.
That's a really good point. So in terms of this discrepancy between clinical application and the latest science, so I learned some new things today, which I'm really encouraged by. And I'm sure that some people listening who maybe heard the old go in a cave and don't do anything advice, are surprised to learn that some light exercise can be really beneficial. When an athlete or a coach or a parent is speaking with a provider or kind of in this situation, how would you recommend that they advocate for some of these newer interventions or treatments if the provider or the medical care team is, seems to be recommending something else, or maybe it's a coach recommending something else? How would you recommend that people kind of advocate for themselves in those terms?
Coach is coach. They don't treat patients. And I think
That's
that
true.
coaches need to know their limitations as well. And one of my frustrations is sometimes when coaches mess things up. Athletes listen to coaches. They've done that their whole lives, right? Coaches have a tremendous influence over athletes. And I don't know if all coaches understand that level of influence can adversely affect an athlete as much as help them. Only because I've dealt with these situations where, a coach wants what's best for their athlete and they heard something from somebody else. Maybe you need this, or maybe you need that. And there's already been a plan set out for that athlete's recovery with their physician. And now we've thrown another variable into it that ends up setting us back. Does that make sense to you?
It really does.
Yeah, I think coaches, before going to an athlete with that suggested, run it by their doc, run it by the team doctor and just say, I heard this. Do you think I should bring it up? I mean, I like coaches to be part of the recovery team. I don't like to say, hey, stay in your lane. I want you to be part of the team, but I don't want you going off and telling my patient something that may hurt us in the long run. Recovery is a team aspect. You need a physical for a high-level athlete. You need your coach on board. You need your physical therapist on board, and you certainly need a physician on board, with everybody having a say in what's best for that athlete if you're going to get them back.
That makes a lot of sense. So it sounds like the best advice for a coach would be to work closely with the care team and make sure that they're communicating constantly with the care team and running any medical related or recovery related suggestions by the care team before the athlete, just to avoid, unintentionally maybe introducing an idea that could be counterproductive.
Yep, exactly.
That's great advice. And for parents or staff members advocating, is it similar? They're just having a conversation with the physician and the physical therapist and just being a part of that conversation?
Sure. Absolutely. Absolutely.
Yeah.
And because there are people out there trying to promise these, quick fixes, and typically they're cash pay, and there's a reason why not everybody's doing it. Just don't believe somebody's got this secret sauce, because it could really mess things up and hurt in the long run. We see that all the time.
It's so tempting because it would be so reassuring to have that silver bullet answer, that secret sauce that's going to make everything okay. So it is hard not to want to buy into those claims and those promises. But
Sure.
You guys are hearing it from an expert here. It's not the way to go.
I hear a new one every day.
I'm sure you do. What do you hope our listeners will remember from this conversation today?
I hope that they'll remember that concussion is real. It could be presenting in a lot of different ways, and that it's not something that is hopeless, that you will get back to your usual level of activity. And if not, part of being an athlete is knowing that there's another direction to go in. And you could also be successful. One of the things, I guess, that in my work with professional bull riders, like most athletes, and I think maybe more extreme with that, because I've learned a lot about Western sports athletes. And we have now advocated for treating them as athletes. I don't think they were treated as athletes. They were treated as kind of an attraction of some type, okay? And rodeo. And gradually now they're starting to see that, you could make real money and compete. But what I try to explain to them is, if your career ends, and it's a short-lived career, an old bull rider's 30, in their 30s, is that, all is not lost when your career ends, whether it be for medical reasons or age-related. Because as an athlete, and especially a self-employed athlete, you've learned how to run a business. You are
That's
a business.
so true.
And it is true, especially in cycling. You've run a business, and you have developed skills that are easily transferable, either staying self-employed or going to work for someone else. And I want athletes to understand that and not feel hopeless when they've had a head injury and they're having symptoms, and if they can't fully recover to their previous level. So I certainly want this to be a hopeful discussion. And I'm hoping we've given people some idea of what the state of the art is in neurology and sports neurology. And as always, I'm available to you or your listeners. If I can be of help, you can put them in touch with me, and I'm happy to assist in either making a referral or being able to give them some helpful advice.
Oh, that's incredibly kind. So Dr. Alessi has a radio show. We'll put links to that in your website. And anybody who does have follow-up questions for Dr. Alessi, you can email me, amber@beagoodwheel.com. If you have questions about referrals, I can pass those along to Dr. Alessi. I really feel hopeful after this conversation. I'm so encouraged by that plasticity of the brain, its ability to heal. I'm so encouraged by the progress that's being made in this area, in this field. And I'll never forget, when I came to see you, I felt so confused and scared and vulnerable. And at one point in our session, you asked me, do you still want to race? And it was a loaded question for me because that year I had already planned to retire from competitive sports. I planned to and hope to ride my bike for the rest of my life, but not as a competitive athlete. But the concussion really threw a spanner in the works. I wasn't expecting that. And I wasn't sure if I wanted to continue racing or not after that. But I remember what you said to me was, there are so many different types of concussions, but there are also as many ways of treating them. And what we'll do is we'll make sure that whatever you decide to do is your decision. And it was the most profoundly hopeful and encouraging thing anyone could have said to me in that moment. So since you're here, I just want to thank you for that. It was genuinely a life-changing moment for me. And thank you for sharing all of this incredible insight and wisdom with all of our listeners.
Amber, it was my pleasure. And it's great to see the evolution of that. I mean, over the course of the past 6 years or so, and how it's worked out. And I'm always gratified when athletes get back to me or, come to me. And sometimes they're coming with their children, okay, who have had concussions. So, which is probably telling me something else. But anyhow, with that, thank you. Thanks for having me.
Thank you, Dr. Alessi.
As you can imagine, Dr. Alessi has a pretty packed schedule, and I'm thrilled we were able to have such an in-depth conversation on this topic. I raced bikes professionally from 2016 until 2018. In that time, I hit the pavement hard enough to break bones on 5 different occasions. Among other crashes forceful enough to break equipment or leave me with substantial road rash. In all of that time, the closest I came to being properly assessed for concussion was to be asked if I'd hit my head. In many cases, no one even posed that question. Honestly, I'm very lucky. Not everyone gets through a career that long without sustaining worse or more permanent damage. But I wish I had known more about concussion from the start. At the very least, I would have been empowered to ask better questions and advocate for the appropriate assessments and care. Of course, our understanding of the brain and brain injuries has come a very long way over that span of time. Dr. Alessi pointed out how quickly both the science and clinical practice can change, and how important it is to seek care from professionals who treat a lot of concussions and work with a lot of athletes. If you just thought to yourself, well, I'm not really an athlete, let me remind you of what Dr. Alessi said about homeostasis. The body loves this state of stable physiological conditions. If you ride on a regular basis, that regular aerobic activity is part of your body's baseline for normalcy. In other words, it's part of those physiological conditions that make up your body's experience of homeostasis. And that's a really important part of determining the best plan of treatment for you. And another reason it's worth seeking out a physician who understands that dimension of treating concussion. 2 takeaways really stood out for me. The first is how important it is to work with a qualified professional, to get assessed and create an individualized treatment plan as soon as possible if you know or suspect you've had a concussion. Doing so can enable you to heal and get back to normal much faster. For some athletes, this can make the difference between missing a couple of days or weeks compared to being out for a whole season or worse. This also means you have a qualified professional guiding your plan for rehabilitation and return to your sport, which can make all the difference if you need someone to advocate for you with a team coach, director, or manager. Not everyone has the same understanding of concussion, and having a well-informed expert to back you up can make a real difference. The second thing that really stood out to me is this. As important as it is to avoid underestimating a potential concussion, it's equally important to avoid becoming overly fearful about concussion. A concussion is a treatable injury, and our understanding of and ability to treat concussion has never been better. Thankfully, this will continue to be true as the medical field continues to advance. No one rides bikes with the intention of falling down, just like no one gets in their car anticipating an accident. Things happen, but that doesn't keep you from driving to the grocery store. The benefits of riding bicycles and engaging in sport far outweigh the risks of injury or accident. And as Dr. Alessi pointed out, most concussions resolve within 2 weeks. Consider the lifelong benefits of riding. Riding improves almost every aspect of well-being: physical, social, cognitive, emotional. These not only span years, but have been shown to persist into old age. Yes, it's important to take concussion seriously, and as much as I don't ever want to get injured, I'll gladly accept the risk of a skinned knee or a couple weeks to rehab a concussion when it means I get to experience the transformative impact on quality of life that comes with riding bikes. Plus, empowered with what we've learned from Dr. Alessi today, we can feel confident that in the case of a concussion, getting care from a qualified professional in a timely manner gives you the best probability for a quick and complete recovery. Dr. Alessi has generously offered to answer follow-up questions and to offer suggestions for how to find specialists where you are. You can email your questions for Dr. Alessi to me, amber@beagoodwheel.com. You can find this and more information, including key points and references from our conversation, in the show notes for this episode. Thank you for joining us for today's episode. This is an abridged version of the full interview. To get full-length and extended versions of each episode, sign up for a membership on Ko-Fi. Memberships start as low as $3 a month. Check out all the perks at ko-fi.com/beagoodwheel. That's ko-fi.com/beagoodwheel to sign up. The Be a Good Wheel podcast is produced by our wizard behind the curtain, Maxine Philivong. If you loved today's episode, don't forget to rate us 5 stars. Until next time, thanks for listening and thanks for being a good wheel.